As more veterans return from deployment overseas and claim a TBI or traumatic brain injury, more trained compensation and pension, or C&P, providers will be needed to document residuals from these injuries for C&P purposes. The purpose of this module is to provide a process for training and certification for general C&P examiners so that they will be qualified to perform C&P TBI exams. In order to become certified, examiners must complete required LMS modules on TBI and pass required examinations. In this presentation, we will review the definition of TBI for C&P purposes and demonstrate how to do a C&P TBI examination. The C&P TBI exam may be documented by using the TBI worksheet as a dictation guide or by using the Capri template. Either method can be used as a guide on how to perform and document a C&P TBI exam. Both methods should provide exactly the same information to the regional office for adjudication purposes. For this presentation, we will use the TBI worksheet as our guide. We will discuss CPEP quality indicators to help examiners include all indicators in their exam reports to achieve a thorough exam that also meets the quality review goals. We will finish with a discussion of several case histories, including suggestions on how to assess whether or not a TBI is present. Before we begin the exam demonstration, we will review the definition of TBI for C&P purposes. The Department of Veterans Affairs issued a training letter. The training letter provides information and guidance about evaluating TBI. VA DoD Common Definition of TBI. TBI is a traumatically induced structural injury and/or physiological disruption of brain function as the result of an external force that is indicated by new onset or worsening of at least one of the following clinical signs immediately following the event. Any period of loss or decreased level of consciousness with or without loss of memory for events immediately before or after the injury. Any alteration in mental state at the time of injury, such as confusion, disorientation, slowed thinking. Neurological deficits which may or may not be transient, such as weakness, loss of balance, change in vision, praxis, paresis, sensory loss, or aphasia. An intracranial lesion such as subarachnoid hemorrhage, intraparenchymal hemorrhage, or contusion. TBI varies in severity and is traditionally described as mild, moderate, or severe. These categories are based on measures of length of initial unconsciousness or alteration of consciousness, post-traumatic amnesia, or abnormal structural imaging. Severity is determined based on clinical status in the first 24 hours after injury, and this does not change. The severity at the time of injury has no bearing on future ratings for C&P purpose. The veteran is classified as mild, moderate, or severe based on meeting any criteria within the highest particular severity level. A mild traumatic brain injury will have normal structural imaging. Alteration or loss of consciousness lasts from 0 to 30 minutes and post-traumatic amnesia from 0 to 1 day. Lowest Glasgow Coma Scale in the first 24 hours will be between 13 and 15. Moderate traumatic brain injury will have normal or abnormal structural imaging. Alteration of consciousness or loss of consciousness will be between 30 minutes and up to 24 hours, and post-traumatic amnesia may last 1 day to 7 days. Lowest Glasgow Coma Scale in the first 24 hours is between 9 and 12. Severe traumatic brain injury may have normal or abnormal structural imaging. Loss or alteration of consciousness will be greater than 24 hours and post-traumatic amnesia greater than 7 days. Lowest Glasgow Coma Scale in the first 24 hours will be between 3 and 8. Glasgow Coma Scale is described elsewhere and is based on best motor responses, best verbal responses, and best eye-opening. The lowest possible score is 3 and a normal score is 15. The purpose of a compensation and pension exam for traumatic brain injury from a general C&P examiner's perspective is not to prove or disprove that the veteran experienced a traumatic brain injury. Rather, it is to document via the guidance of a TBI worksheet or template the extent of disability that the veteran is experiencing as a result of a TBI that occurred during military service. The actual diagnosing of whether or not the veteran has incurred a traumatic brain injury cannot be made by the general C&P examiner. That diagnosis can only be made by one of the following specialists: a physical medicine and rehabilitation specialist, a neurologist, a neurosurgeon, or a psychiatrist. A current diagnosis of traumatic brain injury made by an approved specialist must be documented in the veteran's medical history, in the C-file, CPRS records, DOD records, or in another location. If the general C&P examiner finds that diagnosis in the veteran's medical records, it should be noted in the written exam report. If there is no current formal diagnosis of traumatic brain injury, the general C&P examiner should complete the C&P exam for TBI and send the veteran for a consultation to one of the 4 medical specialists approved to do C&P exams for TBI. The general C&P examiner should address all of the areas in the C&P TBI worksheet or template, but not release it until the veteran's diagnosis is received from the consultant. If the specialist does not diagnose TBI, then any secondary conditions cannot be attributed to TBI. Now that we have presented the criteria and severity rating for TBI diagnosis for C&P purposes, we will review how to conduct a C&P TBI examination by following the TBI worksheet. As for any C&P exam, the first thing the examiner does is review the 2507 AMI exam request from the regional office. Addressing all of the issues in the remarks section of the AMI exam request is a core CPEP quality indicator. Next, the examiner should thoroughly review the claims folder or C-file and review any available medical record in CPRS, Computerized Patient Record System. The examiner should look through DOD records if available and review any other sources of documentation of medical history. After reviewing the C-file and CPRS notes, the examiner will take the veteran's medical history. So I've reviewed your C-file.
Okay.
So I have some information about your deployment and your injuries, but I'd like to get a little more information from you if I may. Can you tell me about your deployment? The first thing the examiner will ask the veteran is the date and nature of the traumatic brain injury. Elicit a statement from the veteran confirming that the TBI occurred in military service, even if it is already documented in the C-file. Noting the date and nature of the reported incident is a CPEP quality indicator. Next, assess and report the severity rating of the traumatic brain injury at the time of injury. This is done using the guidelines described in the Department of Veterans Affairs training letter. The examiner will report whether the TBI symptoms have stabilized and, if not, provide an estimate of when stability may be expected. Stability is typically expected within 18 to 24 months of the initial injury. Indicating or projecting the stability of the TBI condition is a CPEP quality indicator. Next, the examiner should specifically address each symptom or area of symptoms as described in the section of the TBI worksheet labeled A through Z. Since individuals with TBI may have difficulty organizing and communicating their symptoms without prompting, it is important to ask about and document all problems, whether subtle or pronounced, so that the veteran can be appropriately evaluated for all disabilities due to TBI. The examiner must address each one of these signs or symptoms in the sections labeled A through Z and report the findings in as much detail as necessary in a sentence, a paragraph, or more. If the veteran denies problems in an area, the examiner must report this in a sentence or more, such as, headaches. The veteran denies headaches, indicating that the veteran has denied problems in this area. The examiner asking and reporting upon each symptom or symptom area is a CPEP quality indicator. Headaches. The examiner must ask about the frequency, severity, and duration of headaches and whether they most resemble migraine, tension type, or cluster headaches. Identify if the symptoms began proximate to the injury, specifically within the first week, as this is more indicative of a causal relationship. Can you tell me about the headaches?
I feel in the front, over my eyebrows here, it's kind of a dull pain and a much sharper pain towards the lower back side of my head.
For veterans presenting with persistent headache, knowing mechanism of injury can help identify the cause. Acceleration-deceleration injuries often cause whiplash type of injury to the cervical spine soft tissue structures. This commonly leads to headache pain that begins in the paraspinal muscles, semispinalis cervicis, and capitis, and radiates up and forward to the temporal areas. Side acceleration, deceleration, or stretch injuries to the sternocleidomastoid commonly refers pain to the frontal and periorbital areas. Direct impact can cause musculoskeletal headache, and pain locations would vary with the site of impact. Musculoskeletal and cervicalgia headaches usually resolve with time and respond to stretching and range of motion programs. B. Dizziness and vertigo. Ask the patient about dizziness and vertigo. Report the frequency. Any feelings of dizziness or vertigo, spins?
In the midst of a headache, or if I stand up too quickly, I do, for a couple seconds, have to regain my balance. I feel a little bit dizzy. Yeah.
Dizziness and vertigo are common complaints initially in mild and moderate to severe TBI. Mild TBI can lead to benign positional vertigo, characterized by brief, usually 1 minute or less, spells of vertigo or lightheadedness brought about by sudden movements of the head, usually in the sagittal plane. In most cases, it resolves spontaneously 2 to 4 weeks after injury, but can persist up to a year in 3 to 5% of mild TBI. Many cases are related to otoliths in the inner ear and are not typically associated with hearing loss. Other cases are related to injuries of the labyrinthine mechanism, for example, bleeding around or fractures to the inner ear. Early treatment with vestibular rehabilitation is usually highly successful at eliminating symptoms. If dizziness is persistent, then a hearing test should be administered. Cranial nerve 8 disruption due to temporal bone fracture would result in a combination of vertigo and sensory neural hearing loss. C. Weakness or paralysis. If the veteran complains of weakness or paralysis, describe the location. Weakness or paralysis is not typical of mild TBI. D. Sleep disturbance. If the veteran complains of sleep disturbance, describe the type and frequency. How about sleep disturbance?
Sleep disturbance has been a problem. I have a hard time falling asleep.
Identify if symptoms began proximate to the injury, specifically within the first 2 weeks, as this is more indicative of a causal relationship.
Being, of course, tired the next day.
Yeah. Do you have fatigue then?
Yes, I do.
Okay. E. Fatigue. If the veteran complains of fatigue, describe the severity. How severe do you think the fatigue is?
I can't do what I used to be able to do. I'm tired. In fact, I haven't been able to get a full night's sleep. I am nowhere near the energy levels I used to have.
Sleep disturbance and fatigue are very common complaints in the general population and also in a variety of conditions, including psychological disorders, PTSD, anxiety, and depression. When related to mild TBI, They almost always resolve with time unless another disorder is present. Identify if symptoms began proximate to the injury, specifically within the first 2 weeks, as this is more indicative of a causal relationship. F. Malaise. If the veteran complains of malaise, describe. Again, identify if the symptoms began proximate to the injury, specifically within the first 2 weeks, as this is more indicative of a causal relationship. G. Mobility. If the veteran complains of mobility problems, state the symptoms. Any problems with mobility, such as walking, standing, going up and down stairs?
No, ma'am.
Okay, you can run?
Yes.
Mobility problems are not typical of mild TBI. H. Balance. If the veteran complains of balance problems, state any problems. This is not typical of mild TBI unless dizziness is also present. I. Assistive devices for walking. If the veteran is ambulatory, describe what devices, if any, are needed to assist in walking. This is rarely seen with mild TBI unless dizziness is present. J. Memory impairment. How's your memory?
I'm a little more forgetful than I used to be, especially if trying to balance multiple things.
If the veteran complains of memory impairment, describe whether the memory impairment is mild, moderate, or severe. Identify if the symptoms began proximate to the injury, specifically within the first 2 to 4 weeks, as this is more indicative of a causal relationship. Problems with long-term memory, especially memory of events before the injury, are not common with mild TBI and often suggest an alternative pathology. Difficulties with attention and concentration are most common and often lead to difficulties with short-term memory. K. Cognitive problems. If the veteran has other cognitive problems, describe. Any problems with thinking or concentrating, focusing?
I believe I'm a little more distractible. I do have a hard time focusing.
If the veteran complains of decreased attention, concentration, difficulty with executive functions, such as speed of information processing, alternating attention, goal setting, planning, organizing, prioritizing, self-monitoring, problem-solving, judgment, decision-making, spontaneity, or flexibility in changing actions when they are not productive, describe. If the veteran complains of any other cognitive problems, describe. Reports of difficulty with attention, concentration, and memory should always be followed up with objective testing. Identify if the symptoms began proximate to the injury, specifically within the first 2 to 4 weeks, as this is more indicative of a causal relationship. Screening evaluations are often helpful for ruling out cognitive disorders, but if cognitive impairment is found, they are not specific as to the cause of the cognitive disorder, be it a TBI, depression, anxiety, sleep disorder, pain disorder, or other functional deficit. Neuropsychological testing should follow any positive result on screening tests to determine the most likely etiology of the problem. L. Difficulties with speech or swallowing. If the veteran complains of difficulty with speech or swallowing, describe the severity and specific type of problem, such as expressive aphasia, difficulty with articulation because of injuries to the mouth, or aspiration due to difficulty swallowing. These difficulties are not typical of mild TBI. New onset stuttering is rarely a physiologic problem and is not seen with mild TBI. M. Pain. If the veteran complains of pain, describe the frequency, severity, duration, and location of the pain and the likely cause. Other than headache pain, pain complaints are not typical of mild TBI, but are usually attributable to some other mechanism. N. Bowel problems. If the veteran complains of bowel problems, describe the extent and frequency. Bowel problems are not seen with mild TBI and are often a side effect of pain medications. O. Bladder problems. If the veteran complains of bladder problems, report the type of impairment. Bladder problems are not typically seen with mild TBI. P. Psychiatric symptoms. Okay, so I'm going to ask you a little bit about your moods, your feelings. Any problems with mood swings?
I don't believe so, not particularly. No.
Okay. If the veteran complains of psychiatric symptoms such as mood swings, anxiety, depression, or other psychiatric symptoms, describe. If the veteran complains of psychiatric symptoms, a mental health exam should be obtained in conjunction with the TBI exam. While new psychiatric symptoms and diagnosis can be seen after TBI, other than depression, it is rare. Q. Erectile dysfunction or sexual dysfunction. If the veteran complains of sexual dysfunction, state the most likely cause. Sexual dysfunction is not a typical physiologic finding after mild TBI. R. Sensory changes. If the veteran complains of sensory changes such as numbness or paresthesias, describe the location and type. Sensory changes are not typically seen after mild TBI. S. Vision problems. If the veteran complains of visual disturbances, describe. Visual disturbances after mild TBI typically arise within the first 2 weeks after injury if causally related. In mild TBI, visual disturbances are rarely caused by difficulty with visual pathways and are more likely due to problems with executive functioning. T. Hearing problems and tinnitus. If the veteran complains of hearing problems, such as decreased hearing or tinnitus, describe. If so, the veteran will need to be scheduled for an audiology exam in conjunction with his TBI exam. Common auditory complaints after mild TBI, such as tinnitus, will be seen initially in the first 2 weeks if causally related. U. Decreased sense of taste or smell. How's your sense of smell?
I believe my sense of smell is fine.
Okay,
as well.
you're tasting food okay?
Yes.
Okay,
Yes.
your appetite's okay, you're eating?
Yes.
If the veteran reports a decreased sense of taste or smell, describe using the examination protocol for the worksheet for sense of smell and taste. The olfactory nerve is the most commonly injured nerve in mild traumatic brain injury. However, this is still a rare finding in mild TBI. Impaired sense of smell is often manifested as a loss of taste rather than a complaint of loss of the sense of smell. Veterans may lose weight due to their loss of sense of taste and smell. Check for functional loss of cranial nerve 1 in any patient with report of loss of sense of taste or smell. V. Seizures. If the veteran complains of seizures, describe the type and frequency. Seizures are extremely rare sequela of mild TBI, occurring in less than 0.5% of cases. W. Hypersensitivity to sound or light. If the veteran complains of hypersensitivity to sound or light, describe. These findings will be seen initially in the first 2 weeks if causally related. They are often associated with secondary psychological issues. X. Neurobehavioral symptoms. Any feelings of being irritable or restless? If the veteran complains of neurobehavioral symptoms such as irritability, restlessness, or other neurobehavioral symptoms, describe.
A little more on edge and things that wouldn't normally bother me or set me off tend to do so a little.
On edge. Okay.
Yes.
Neurobehavioral symptoms are common in moderate and severe TBI. In mild TBI, they may indicate untreated anxiety, depression, post-traumatic stress disorder, or post-traumatic stress symptoms. With treatment of these other disorders, the neurobehavioral symptoms will typically improve. The common behavioral symptoms seen in the first several weeks after mild TBI include irritability, and difficulty with interpersonal relationships, such as with spouse, children, or coworkers. Has that impaired your ability to interact with people at all?
It's made me snap at people that I wouldn't normally do so. And
These symptoms are typically manifest in the first 2 to 4 weeks after injury, if causally related. Why? Autonomic dysfunction. If the veteran complains of symptoms of autonomic dysfunction, such as heat intolerance or excess or decreased sweating, describe. Symptoms of autonomic dysfunction are not typically seen with mild TBI. Z. Other symptoms. If the veteran complains of any other symptoms, describe. Possible other symptoms include endocrine dysfunction or cranial nerve dysfunction. Negative as well as positive responses to symptom areas A through Z must be documented. Showing that the examiner asked about each of the TBI symptoms or symptom areas labeled A through Z is a CPEP quality indicator. After completing this portion of the patient's history, the examiner should report on the course of the symptoms described, stating if they are improving, staying the same, or worsening in severity. The examiner should also report the frequency of the symptoms and whether or not they are stable. Describing the course of the TBI symptoms is a CPEP quality indicator. The examiner should report any current treatments, the condition for which each treatment is being given, the response to treatments, and any side effects, if present. Treatments and response to treatments is a CPEP quality indicator for TBI. Describe any effects on the veteran's routine daily activities or employment. How has this affected your routine daily activities or your, for instance, employment?
It's just a feeling of discomfort and wanting to be, again, just be back to normal. I have anxiety and my lack of attention. But otherwise, I still work. I'm
You're
okay.
still working?
And things are okay at home.
Okay. Providing functional impairment information is a core CPEP quality indicator. After completing the veteran's history, the examiner will perform the physical examination. Part 1, motor function. Test and report motor strength for all major muscle groups using the standard muscle grading scale. One example of appropriate documentation would include strength is 3 out of 5 of left forearm flexion. To the extent possible, identify the peripheral nerves that innervate any weakened or paralyzed muscles, even if weakness or paralysis is of central origin. Can you please push your arms like this? Okay, hold them up real strong. Don't let me push them down. Okay, hold them there. Don't let me pull. And don't let me push. Don't let me pull. Don't let me push. Okay, hold your wrists in that position. Very good. Spread your fingers real wide apart, please. Hold them apart real strong. Very good. And hold them like this. And hold them apart. Very good. Okay, put your hands in your lap. And can you please lift up this knee? You can put your hand at your side. Hold it up real strong. Very good. The other side, please. Hold it up real strong. Good. Straighten out this knee, please. Hold it up. And straighten out that knee, please. And hold that foot up. Okay. Pull your heel towards the back of the table, please. Good. And this side, back of the table, bend that knee. Good. Okay. Hold your feet up at the ankles. Hold them up real strong. Okay. And push down like you're stepping on the gas. Good job. Describing motor function according to this standard muscle grading scale from 0 through 5 is a CPEP quality indicator. Part 2, muscle tone and reflexes. Going to move your arm around, just try to relax it. Describe any muscle atrophy or loss or increase of muscle tone. If any muscle atrophy is found, the examiner must measure and report circumference of the affected and unaffected extremities. I'm going to tap on your reflexes now. Okay. Just stay nice and relaxed if you can. Examine and report muscle stretch reflexes and any pathological reflexes. Okay. Good. all right? Part 3, sensory function. Okay, I'm going to test your sensation. Can I see your hands on both sides? Does this feel sharp like a pin?
Yes.
Sharp like a pin? Describe the exact location of any area of abnormal sensory function. Same on both sides. State which modalities of sensation were tested, such as pinprick, light touch, vibration, temperature, or position sense. Identify the peripheral nerve and, if applicable, the root level that innervates the areas of abnormal sensation.
Up, down, up.
Good.
Down, up, down.
Thank you. That was sensation to pinprick and proprioception. Part 4, gait, spasticity, and cerebellar signs. Describe the veteran's gait. A tandem gait assessment is recommended. Describe any gait abnormality, imbalance, incoordination, or spasticity. Assess any limitation of gait that is caused by joint rigidity or spasticity of muscle movements. If limited joint motion is found, follow the joints examination protocol on the joints worksheet. Part 5, autonomic nervous system. Okay, can you sit up, please? Describe any apparent impairment of the autonomic nervous system, such as hyperhidrosis, heat intolerance, or orthostatic or postural hypotension. Do you feel any dizziness?
No.
If orthostatic hypotension is present, report whether or not it is associated with dizziness or syncope on standing. No signs of orthostatic hypotension. Part 6, cranial nerves. Would you close your eyes, please, and tell me what this smells like? Conduct a screening exam for cranial nerve impairment. Cover up one eye, please. If positive, follow cranial nerves examination protocol worksheet.
2.
Okay, very good. Please cover up the other eye. And how many fingers?
3. 2.
Okay, very good. Okay, can you please hold your head still and follow my finger with both eyes? Okay, it's going to come towards your nose. Okay, very good. Okay, you can just pick a spot on the wall and look right at it. Check on pupillary reflexes. Okay, and then look right at the spot and try not to move your eyes. Very good. Okay, same thing. Pick a spot on the wall, try not to move. Okay. Okay. Does this feel the same on both sides?
Yes.
The same on both sides?
Yes.
Same on both sides. Okay, bite down, please. Okay, very good. Can you raise your eyebrows, please? And close your eyes shut really tight. Don't let me open them. Okay, and smile. Very good. Okay. Do you hear my fingers tapping?
Yes.
Okay. Hear my fingers tapping on this side?
Yes.
Let me know when it goes away.
Now.
Okay, and let me know when it goes away.
Now.
Very good. Okay. Can you please open and say ah? Okay, very good. Stick your tongue out to the front and to the side, the other side. Very good. Okay. And could you please turn your head against my hand? Very good. And now the other side. Okay, very good. Could you please shrug up your shoulders? Hold them up real strong for me. Okay. Part 7, cognitive impairment. Conduct a screening cognitive examination. If the screening test or interview shows problems with memory, concentration, attention, or executive functions, neuropsychological testing must be obtained to confirm and assess the extent of cognitive impairment. If the veteran performs poorly on a screening test, neuropsych testing is clearly indicated. However, Even if a veteran performs well on a screening test, neuropsychological testing may still be indicated because of the insensitivity of the screening examinations to the often subtle cognitive deficits of mild TBI. Based on the nature of the injury, clinical observation, and the veteran's complaint, neuropsychological testing may be warranted. You must include a summary of the results of the neuropsychological testing in your examination report. Providing neuropsychological test results in your report is a CPEP quality indicator.